Welcome, students. We are going to start Chapter 11 today, Evaluation and Management. Another word or another abbreviation I always use is E&M services. So with this, I want everyone to go ahead and go to the Evaluation and Management section of your CPT book. Also, I want you to open Chapter 11 in your step-by-step book. And I'm going to start with a little lecture here. It's probably going to be 2. This is a very big section. So let's start off with here, coding for services. What is E&M? This is for the physician to get paid for their service. This is not for the physician doing any surgeries or procedures. This is completely for the physician or health provider doing a service for a patient. One thing to do, or not to do, I should say, it is never appropriate for the coder to make assumptions that go beyond the information provided. Going back to if it wasn't documented, it wasn't done. So your job, never maximize. You only want to optimize. So you're going to take that documentation and get the most out of it. You're not going to take it and try to increase it when there's not enough information there to make it more, a higher level service. Once again, if it wasn't documented, it wasn't done. And here we go. It's a crime. So if you would code for a service that was not provided, it is a crime. So if you're trying to bill for a higher service, that is basically fraud. So you're billing for services that were never rendered. So Chapter 11 reviews. We are going to look at E&M section. Keep in mind, once again, this reports physician services. Diagnostic services provided by a physician in any context would be coded via E&M codes. So keep that in mind. These would include services provided in the physician office, to patients in a nursing home, extended care facility, to inpatients and outpatients. Let's break down the subsections by type of service. So we're going to start off with the different types of service. It can be an office visit, acute care visit, hospital visit. So let's talk about the hospital visit. This would be when a doctor comes in and sees a patient in the hospital on a daily basis. They get paid for it. When a physician or provider admits a patient to the hospital, they have to do a history and physical, they get paid for that. Or if they have to go in and provide a consult for a patient. All right, so let's go ahead, the 3 factors of the E&M coding. We have place of service, type of service, and patient status. Let's start with place of service. This explains the setting of service. So in the office, patient comes into the office, patient comes into the emergency department, patient is in the nursing home, and the doctor comes to the nursing home to see the patient. Those are the different settings. Types of service. Physician provides many types of services. This could be an office visit. They could admit the patient, do a consult, and prolong services. Patient status. We will talk about these a little bit more. We have new, established, outpatient, inpatient. So, office or other outpatient code guidelines. With this, January 1st, 2021, the AMA incorporated new CPT guidelines. Codes 99202, 99215. This only was for them. 99201 was deleted. Code selection was based on medical decision making. This has been great, and I'm sure as we get into this, you're all going to like this a lot. And then time is listed in the description for each code, which is going to be easier for you to decide what level to use. Medical decision making. This focuses on the elements that affect the management of a patient's condition. instead of adding up all the tasks. So in the past 2 years, students had to add up tasks from the history, from the exam, and then medical decision making to come up with a code. This year, 2023, the majority of the codes are based on just medical decision making. Time is the other thing. So we're really looking at time for a lot of these. One thing you need to look at when you look at time. What does time all include? This is reviewing documentation results, obtaining a history. Okay, so when a patient goes in, they always have a history. The doctor wants to know past medical social history. Performing an exam evaluation, counseling, ordering meds, tests, procedures, if they communicate with other healthcare professionals. So this could be, let's say, my tiny town of Dubuque, I shouldn't say tiny, but let's say they consult with somebody from the Mayo Clinic or they consult with somebody at the University of Iowa hospitals. Documentation in the health record, they look at that, interpreting results, communicating to the patient, and coordination of care. Documentation of counseling, coordination of care is not required. Okay, let's talk about quickly here the difference between a new patient and an established patient. So with that, a new patient is someone who has not received any professional service in the last 3 years. So this would be from the same physician, another physician of the exact same specialty and subspecialty in the same group. So let's talk about new patient. So I'm going to go with Medical Associates. We are a big clinic, or it is a big clinic, and they have lots of different specialties. There's internal medicine, there is neurology, cardiology, OBGYN. So anyway, let's just say that the patient has high blood pressure. They're going to internal medicine. First time they went in, they go ahead and see Dr. Smith. Dr. Smith puts them on a medication and says, come back in 3 months. New patient. So 3 months, Dr. Smith is not there. So they have to go to Dr. Jones. And Dr. Jones, different physician, but they are not a new patient because they're in that same specialty. All right, so 6 months later, I'm out walking or jogging, let's just say jogging, make it sound better, and I trip, break my ankle. So at that point, I have to go to orthopedics because I have a broken ankle. I am a new patient, even though it's at Medical Associates, the same facility. I have to go and see an orthopedic doctor, so I am new. I am new to that specialty. So just keep in mind, it's within 3 years is what you need to know. Where an established patient has received professional services in the last 3 years. So from the same physician, another physician of the exact same specialty, subspecialty in the same group. Medical record is available with current relevant information. So that is the difference between new and established. Let's go ahead and talk about outpatient. This is one who has not been formally admitted to a healthcare facility. Example, a patient receives service at a clinic or same-day surgery center. So whether they go in for an office visit or they go to a same-day surgery center to have something minor done like a colonoscopy, I guess that wouldn't be minor, but having possibly a patient goes in for cataract surgery. These are all same-day or outpatient visits. Also outpatient is observation. This is where they're admitted, let's say through the ER to observation. You go in for chest pain and they say, you know what, we don't want to admit you, but let's put you in observation. That is also outpatient. Inpatient. This is one who has formally been admitted to the healthcare facility, hospital, nursing facility. The attending physician dictates admission orders, history and physical, and request consultations. Not all the time, but they can request a consultation. So let's talk about the different levels of E&M service. They're based on medical decision making, total time spent. This, just a couple of different things. This is so much easier for students since they've changed this in 2023, because right now you're just looking at one aspect. You're still looking at the history and examination, but you just need to know that they need to be appropriate, that they covered them both. So our E&M is based on key component, contributory factor, and every encounter contains varying amount of both of these. Encounters, more of each component factor gives you a higher level of service. The less, of course, is going to be a lower level of service. Key component is medical decision making. Let's go back to that. To some extent, the key component, when we look at this, is going to be for the patient encounter. So the reason that these can be differ because the complexity of the decision making is going to depend on which condition can be diagnosed and how the treatment is going to be recommended. So we look at, this is a great example, level of medical decision making could be if somebody comes in with just a chest cold, all right? But if they have a severe chest cold, this could make the complexity go up higher because at that point, time, resources, decision making could be a lot more. All right, so 3 elements in medical decision making are element 1, the number of diagnoses, minimal, low, moderate, or high. We're not going to base this so much this year in beginning CPT. You are going to have to figure this out next year once we get to the advanced level. Then the element 2 is going to be the amount of data to be reviewed, minimal or none, limited, moderate, or extensive. Element 3 is the risk of complications, minimal, low, moderate, or high. So then we have our 4 levels of medical decision making complexity. This year, once again, you will have these given to you. So everything will state straightforward, low, moderate, or high, or it will be based on time. So we have straightforward, minimal. You can see everything's minimal. Low medical decision making, limited, low. See how these 3 key components are hitting everyone? Just it depends on what level. And then high, everything's high, extensive, high. Data reviewed order. This just talks about the different data reviewed. A review result should be documented in the medical record. This is great for you to go through this year to realize this is what it takes for medical decision making. But I'm not going to go, once again, overly on top of this because we'll really dig into this next year in the fall. All right, so we go through each level, the risk, high risk. So once you figure everything out, 2 out of the 3 categories must meet or exceed the elements stated to assign the level. So at this point, if I have, let's just say I have a low and a low, but my complexity of data was moderate, I would still code low. So you won't have to do this year, but you can still look at the charts. Okay, so I kind of want to move on to, we're going to look more here at the time. There is a time factor, and with the time factor, this is physician and patient together, face to face. It's the total time documented in the medical record. So unit floor time is time spent by the physician on the patient's floor unit, also at the patient's bedside. You can also, if the patient spends 10 minutes reviewing the patient record and then is with the patient, this is all lumped into that one-time component. So the use of the E&M code, they're grouped by the type and place of service, consult, office visit, and hospital admission. So as of January 21, AMA incorporated new CPT guidelines for 99202 through 99215. One nice thing, they eliminated the history and physical exam portion and now only base the selection on medical decision making or time. As I stated before, you will be given the time for this semester and you will be given the medical decision making. In the fall, you will have to figure out the medical decision making. Let's go ahead and have you open your CPT book to 99202, CPT book. Okay, so let's go ahead and look at code 99202. It's right at the beginning of the E&M section. This is office or other outpatient visit. New patient. Keep in mind, new patient. Let's look at the definition. This is for the E&M of a new patient, which requires medically appropriate history and or examination and straightforward medical decision making. When using time for this code, 15 to 29 minutes of total time spent on the date of the encounter. So either your problems this semester is going to tell you the time or it's going to give you the level of decision making. So this is an office visit. This is somebody who goes in and is seen for strep throat, hypertension, maybe diabetes, or they're going in because they have abdominal pain or they're having bowel issues. So anything in that category is going to be your office or outpatient codes. So if you look at 99211, this is established. You are no longer a new patient. Once again, it goes through the different levels and what those levels are. So if I look at 99211, this is the E&M. Actually, that one does not require the presence of a physician or qualified healthcare professional. This is what I'd like, and go ahead and write this in your book. So 99211 could be somebody going in just having a blood pressure check by the nurse. The nurse can, for the facility, charge this. Or going in for, let's just say, I would say probably blood pressure is the best example of this. Then we go into 99212. This would have to be from a healthcare provider. And as you can see, the decision making straightforward, and the time on this is 10 to 19 minutes. So with this is all our office visit. We go from new to established. All right, I'm going to take a break from this video and then make sure you tune into the next video as we keep going on the E&M section.